Right. So as I mentioned, I think for any initial bladder tumor diagnosis, TURBT is the standard of care, and I think has to be the first option, right? You have to make sure that you grade appropriately and you stage appropriately. Following that, I think anytime a patient who has low-grade disease recurs, I think as you have a conversation with the patient, I think I will always introduce both options. I think patients should be aware of both options. If a bladder tumor recurred for the first time and it's small in 3 or 4 years, I may even watch that patient and do what's called surveillance. I mean, I'm just going to keep an eye on that small tumor recurrence, but I'm not going to say subject them to a significant treatment. It took just 3 years to form a small tumor. I might even zap or fulgurate that in the office and really do nothing more than that. For patients where the tumors are coming back more quickly, they're larger, they're more multifocal, I think for many patients who are kind of in that boat, I think the opportunity to use something like UGN-102, especially if they failed TURBT in the past, I think becomes, in my opinion, one of the primary options that I would offer to a patient. So, there's a lot of factors, and I think this is sort of the beauty of medicine, is that everything is really individualized to patients. Patients get to weigh in on their preferences as well. But I think that you're going to find that for patients that recur frequently with TURBT, patients who have anesthetic complications like we talked about, or risk factors for anesthesia. And I think some patients who just really suffer from a TURBT, there are patients who describe urinary symptoms for weeks after a TURBT. These patients are going to be very excited to have something that doesn't require any of those types of management options and can really be done in the office. The last group are patients where they worry about the burden of disease on their families. So there are patients who have to travel long distances. They have to have someone drive them back and forth. Maybe a child has to take the day off from work because of the anesthesia and then watch the next day. Now these patients can arrange for the drug to be given in the office where they can drive themselves back and forth to the visit. They don't have to spend a lot of time in our offices, and they can really sort of ease the burden on their family members. So I think a lot of this is going to be sort of offering it to patients, talking about the data, explaining the complete response rates and the durable response rates, and then I think really offering it to patients where it's really something that they're interested in doing and you think is appropriate to do. Again, for me, there's not a lot of patients where I think that that's not appropriate, and I think that patients should be able to choose the type of treatment options that they would like, especially when you have one that I think has very strong initial complete response and very, very strong durability response. Yeah, so I think it's a really exciting time to be involved in non-muscle invasive bladder cancer in general, and I think specifically for low-grade intermediate risk disease. So maybe over the last 5 years, I think the majority of highlights have been in the BCG unresponsive space, where a number of FDA-approved agents have sort of come on board and really helped us to preserve bladders. Some of these agents, nadofaragene, cretostimogene, these drugs are now being studied in the intermediate risk space as well. Primarily in the adjuvant setting to prevent recurrence. But I think these are pretty powerful drugs, and they may allow us to have patients get a TURBT, have those types of treatments, and then not recur for a long time. So, novel agents in the adjuvant space, I think, are really exciting. There's new agents that are being studied in subpopulations of low-grade disease with FGFR mutations. The TAR product, for example, is a product that allows a slow release of gemcitabine. It gets swapped out every 12 weeks with a cystoscope, and has sort of the same concept of a slow releasing treatment that sort of provides constant contact and helps to ablate tumors. There's an oral agent that's being studied, which would obviate the need for any catheters. So I think the space itself is really exciting, and I think urologists are going to find more and more conversations, more and more presentations about how to manage this low-grade intermediate risk space. Right now, we only have one FDA-approved agent, which is Zysturi, and so I think that sort of becomes the conversation in the summer and fall of 2025. But I think it's important to kind of keep alert, because I think there'll be more and more options for our patients. And again, that's only to the betterment of our practices as well as our patients' journeys in this disease space. Everything we can do to minimize the burden of disease for low-grade disease is important, because patients do not die from this disease, but they certainly have suffering sometimes from the types of treatments that we offer. So I think a really exciting time. Potentially what I've been hearing from urologists is using the word paradigm shifting. And I think we sometimes overuse that phrase, but one could argue it's really appropriate here, right? You're taking something surgical that has always been surgical and now offering a non-surgical approach. And it's just really, really exciting to be part of that, and also to be able to discuss this with other urologists and with my patients. The drug is now approved And so I think what I tell patients, and I tell my partners and other urologists who are interested is, this is a time to gain experience with novel agents, right? So the easiest way to do this is to identify the patients that you think are the best ones. And again, we've talked about some of the subtypes: frailer patients, recurrent patients, multifocal patients, patients that you can't resect completely. I think you can start with any patient, but certainly those are patients where TURBT and the standard approach isn't that successful, and obviously an easy sort of launching point for many of us, and gain familiarity with the agent and the process. Really easy to do. The company is UroGen. They have a very similar chemoablative agent in the upper tract called JELMYTO, which has been in the market for a few years. And so a very similar concept, and reaching out to UroGen once you've identified a patient, let them help you sort of navigate the administrative components of things. We talked a bit about it having to be chilled prior to administration, how it's delivered to your office, buying and billing, as well as the financial aspects to administering any novel agent. But again, my advice is, our job as the urologist is to identify patients who may be eligible, and then let the companies help us to find a way to get those new agents to our patients that we think are appropriate. So I've always really advocated for any of the new agents that we have, because there's many of them in the non-muscle invasive space, both intermediate risk, low grade, now with Zosturi, but as well as the BCG unresponsive space, is gain familiarity with these products. You'll find that they're really easy to give. You'll find that they're really easy to integrate into our practices, and you're going to help patients. And so don't let the barrier of something new be a barrier to utilizing it. It's now on the market, and UroGen, I think, is well equipped to help us have our patients that we've identified receive that new agent. So again, find those patients that you think are going to benefit the most, gain familiarity, and this is probably going to be part of bladder cancer management for the rest of our lives, which is really exciting, and it really begins now.